So we'll start discussing these genitourinary condition one by one. So the risk factor for developing bacterial vaginosis and candidiasis is the use of broad spectrum antibiotics. Broad spectrum antibiotics can lead to death of normal vaginal flora. So there's a good chance for the development of bacterial vaginosis or vaginal candidiasis. Now, some features of trichomoniasis or trichomonas vaginalis. Remember that for trichomonas vaginalis and vaginal candidiasis and bacterial vaginosis, the swab that we need to take is high vaginal swab. So if you are suspecting any three of them, then the swab that you need to take is high vaginal swab. And if you're suspecting chlamydia or gonorrhea, and then endocervical swab will be taken. While for the screening of chlamydia and gonorrhea, self-collected vulvovaginal swab is the swab of choice. So high vaginal swab for trichomoniasis, bacterial vaginosis, and candidiasis. Endocervical swab for a symptomatic female with a suspicion of chlamydia or gonorrheal infection. And in asymptomatic women, for screening, self-collected vulvovaginal swab. So the patient with trichomoniasis will have a yellow greenish smelly vaginal discharge, vaginal itching, strawberry cervix, and the vaginal pH will be more than 4.5. Because it is a protozoal infection, so treatment is oral metronidazole. In investigation, two things can be done. One is to check the pH of the vaginal discharge, and if the pH is more than 4.5 and a high vaginal swab will show motile flagellates on microscope. So this is another differentiating feature for trichomoniasis. Because they have flagellum, they can move freely. So you will see motile flagellates on the microscope, and also the other feature that is specific for trichomoniasis is yellow greenish discharge. The treatment is oral metronidazole. The second infection is bacterial vaginosis, that is also caused by the risk factor for bacterial vaginosis is use of broad spectrum antibiotics or immunosuppression. In trichomoniasis, there was a yellow greenish discharge, while in bacterial vaginosis, there will be gray white discharge with very fishy or offensive smell. The pH in bacterial vaginosis will also be more than 4.5. It was more than 4.5 in trichomoniasis as well. Now, what are the difference between these two? In trichomoniasis, itching is common, while in bacterial vaginosis, itching is uncommon. In trichomoniasis, the discharge was yellowish greenish, and in bacterial vaginosis, it is gray-white. And also, in bacterial vaginosis, there will be a positive whiff test. What is a whiff test? If we add potassium hydroxide to the discharge, to the vaginal discharge, it will produce a very fishy odor. So let's repeat the differences between trichomoniasis and bacterial vaginosis. The first is, difference is the discharge. If there is a greenish discharge, then it is trichomoniasis. If it's gray-white, then it's bacterial vaginosis. Itching is common in trichomoniasis while it is uncommon in bacterial vaginosis. And in bacterial vaginosis, there will be a positive whiff test. The treatment is almost same, metronidazole plus clindamycin. The swab that is taken for to make a diagnosis of bacterial vaginosis is also a high vaginal swab. There's EMSIL's criteria to make a diagnosis for bacterial vaginosis. There are four criteria. Three of them must be present to make a diagnosis of bacterial vaginosis. The first criteria is a white discharge, a gray white discharge. The second is positive whiff test. The third is clue cells. And the fourth is pH more than 4.5. What are clue cells? Clue cells are basically epithelial cells that are covered with gram-negative rods in the microscopy. So the microscopy findings for trichomoniasis is motile flagellates on the microscope, while in case of bacterial vaginosis, there will be clue cells. So this is another difference between these two. EMSIL criteria, 3 out of 4 of these criteria should be present to make a diagnosis of bacterial vaginosis. Now the third condition, and that is vulvovaginal candidiasis, vaginal thrush, or that is caused by Candida albicans. Just like bacterial vaginosis, the discharge here will be white, but it will be thick white, cheese-like discharge and odorless vaginal discharge, while the discharge in bacterial vaginosis was offensive or fishy odor. And the pH here in vulvovaginal candidiasis will be less than 4.5 or up to 4.5, but not more than 4.5. So it's easy to differentiate it from other two bacterial vaginal infection, because in bacterial vaginosis and trichomoniasis the pH was more than 4.5, while here the pH is 4 to 4.5 and not more than 4.5. The discharge will also be thick, white, and cheese-like because it's a fungal infection. Local cotrimazole is the treatment for vulvovaginal candidiasis. The investigation that is done in all these three cases is checking the pH of the secretion and taking a high vaginal swab. So white and thick discharge, candida, yellow greenish discharge, trichomoniasis, along with vaginal itching and pH more than 4.5, and on microscopy motile flagellates, offensive discharge without itching, fishy smell, pH 4.5, clue cells on microscopy. The diagnosis is bacterial vaginosis. Now, a scenario: a young lady presents with offensive vaginal discharge. She is sexually active with a single partner. Her vaginal pH is 5.5. High vaginal swabs are taken for culture. What is the most likely diagnosis?
Bacterial vaginosis.
Why not trichomoniasis?
Because no itching.
Offensive vaginal discharge is actually active. There's no mention of itching. Remember that bacterial vaginosis is more common than trichomoniasis. So that's why if a scenario like this come in the Plab 1 exam and you are confused between two diagnoses, so you need to mark the most common one. Because offensive vaginal discharge, nothing is mentioned about the color and nothing is mentioned about the itching, and the pH is also more than 5.5. So the answer here will be bacterial vaginosis because it is more common than trichomoniasis. Though bacterial vaginosis is not a sexually transmitted infection, but it is common in sexually active females. So that can also be a hint to make a diagnosis of bacterial vaginosis. So chlamydia and gonorrhea, they can cause urethritis, dysuria, and urethral discharge in males. And if the infection ascends upward, it can result in eczema orchitis, epididymitis, or unilateral testicular pain. While in females, it can cause postcoital bleeding, intermenstrual bleeding, or cervicitis, or it can also cause pelvic inflammatory disease. We have discussed this already. The treatment is doxycycline before azithromycin. That is a mnemonic to remember the treatment. Doxycycline 100 milligram BD for 7 days, or azithromycin 1 gram followed by 500 milligram OD for 2 days. Doxycycline is contraindicated in pregnancy. So if a woman presents to you with the suspicion of chlamydial infection, then we'll use azithromycin. While the treatment for Neisseria gonorrhea is C or C, ceftriaxone, single dose of ceftriaxone, or a single dose of ciprofloxacin. Endocervical swab and high vaginal swab. Endocervical swab will detect chlamydia and gonorrhea, and high vaginal swab will detect all the remaining three: Trichomonas vaginalis, bacterial vaginosis, and Candida. So if a woman presents to you with vaginal discharge, then you need to take an endocervical swab as well as a high vaginal swab to rule out all the infections. A 20-year-old female with a new sexual partner presents with increasing vaginal discharge that is yellow greenish. The best single investigation is endocervical swab and high vaginal swab. So when you will go for a self-collected vulvovaginal swab, if a woman is asymptomatic and you are suspecting a STI, sexually transmitted infection, then you will select self-collected vulvovaginal swab. In case of trichomoniasis, microscopy will show motile organisms, while in case of bacterial vaginosis, glue cells will be seen on microscope. So in short, for screening of chlamydia and gonorrhea, self-collected vulvovaginal swab, signs and symptoms of chlamydia and gonorrhea, endocervical swab, suspected trichomonas vaginalis, high vaginal swab, and to cover all possibilities, endocervical swab and high vaginal swab. Well, so this was a sample of choice in females, while in men, first catch urine sample is the specimen of choice, or a urethral swab is an alternative. So the specimen of choice is FCU, first catch urine, or if this option is not given in the options, then a urethral swab can also be an alternative. What about extragenital samples? Uh, MSN, men who has sex with men, on those people, rectal swab also need to be taken. So this was all about chlamydia, gonorrhea, and other vaginal infections such as trichomoniasis, bacterial vaginosis, and candidiasis, etc. Is it clear up to this point, everyone?
Yes.
So now some more genitourinary infections. Syphilis. Syphilis is caused by Treponema pallidum. There are four stages of syphilis: primary stage, secondary, tertiary, and quaternary stage. How you can differentiate between these three stages, four stages? In the primary stage, there will be a single painless genital ulcer at the site of sexual contact. So a single painless genital ulcer, it will be a primary stage of syphilis. Secondary stage of syphilis is usually after 6 weeks of the ulcer, and it is characterized by the most important finding of secondary stage of syphilis is rashes on soles, palms, and face. While in tertiary stage of syphilis, there will be cardiovascular involvement, such as aortic aneurysm or aortic regurgitation. And if there is neurological involvement as well, then we will call it as quaternary syphilis. So a single painful ulcer, primary syphilis, rash on palms and soles, secondary syphilis, cardiovascular involvement, tertiary syphilis, neurological involvement, quaternary syphilis. The treatment of syphilis is intramuscular benzyl penicillin. If a person is allergic to penicillin, then doxycycline can also be taken for the treatment of syphilis. Now, how to investigate a syphilis? What are the different scenarios? When you will go for dark microscopy, when you will go for a PCR, and when will you go for serology. So if the patient is presented to a specialist genitourinary clinic, then we'll go for a dark microscopy. So read the question statement carefully. If it's mentioned that the patient presented to you in a GU clinic, then you will select dark microscopy if the ulcer is still present. And if the ulcer is present and the patient present to you to the GP clinic, then you will go for PCR. So if the ulcer is present, then you have two options, either a dark microscopy or either a PCR. If a patient present to you in a specialized clinic, then dark field microscopy. And if he is presented to a GP clinic, then PCR. But if there's no ulcer, the ulcer has healed, then you will go for syphilis serology. So a single painless ulcer, the diagnosis is syphilis. A single painless ulcer, the diagnosis is syphilis. Now, multiple painful ulcers, the diagnosis will be herpes simplex virus or genital herpes. Single painless ulcer, syphilis, single painful ulcer, Haemophilus ducreyi, multiple painful ulcers, HSV or genital herpes. How to investigate genital herpes? The first line investigation is NOT testing. Other tests that can be used include viral culture plus a DNA detection using PCR. And if PCR is negative and viral culture is negative and the ulcer is recurrent, then anti-HSV antibody testing will be done. So the first line investigation for genital herpes is NOT testing. If it cannot be confirmed or not testing, then we will go for viral culture and DNA detection using a PCR. And if they are negative as well, then and the ulcers are recurrent, then we'll go for HSV serology or anti-HSV antibody testing. The treatment for syphilis was benzyl penicillin, and if the person is allergic to penicillin, then doxycycline, while the treatment for HSV is acyclovir. Now, there are some terms that we need to understand to pick a scenario of genitourinary infection correctly. MSM stands for men who has sex with men. There's usually a top and a bottom. These are general terms. Top is insertive sexual intercourse. If it is mentioned in the question that the person is top, then you need to take a urethral swab or first wide urine or first catch urine sample for microscopy and culture. And if he is bottom, then you need to take rectal swab for NOT testing. All MSM should need to be screened for HIV, hepatitis B, chlamydia, and gonorrhea. So these are four important sexually transmitted infection in MSM, and they are chlamydia, gonorrhea, hepatitis B, and HIV. We have discussed that high risk HPV such as uh, 16, 18 cervical cancer, and low risk HPV such as HPV 6 and 11, they can cause genital warts. So if a male or a female present to you with painless growth-like lesions, such as benign cauliflower-like growths, then the diagnosis will be papilloma that is caused by HPV 6 and 11. Gardasil can be used. Gardasil is basically a vaccination that is used for the prevention of genital warts. So the treatment for genital warts include the vaccine for genital warts that is caused by 6 and 11, and also it can provide protection against cervical cancer that is caused by 16 and 18. It is used for the prevention because it is a vaccine. So if the patient has developed the warts, then there is no use to use Gardasil. The treatment include chirotherapy. 30% of the cases are spontaneous resolution in 6 months, so they usually does not require any treatment. So genital warts are caused by HPV 6 and 11. The treatment is chirotherapy and the prevention is Gardasil vaccine. So we are done with genitourinary infection as well. Tomorrow we will start with obstetrics. So until then, someone want to ask any question, and then they can ask.